Afgaristo, manus and manus, this is what I know. This is the only word I know. So I changed, I have 4 talks about lower trapezius, 4. so, so I changed them yesterday. Yesterday after the dinner, we spoke with some of the audience, so I changed them accordingly. So the first talk is gonna be about massive rotator cuff tear, but I'm gonna focus about anterior superior. Then I'm gonna talk about the trapezius but in implant. Then we'll talk about trapezius for massive rotator cuff tear. This is from last night. This is Jean Cani. When he gets drunk, he's very funny, by the way. He's very cute. Anyway, I think as Mahata said and Clara talked about, it's always good to restore anatomy if we could, or biomechanics. And this is where tendon transfer sometimes comes into play and become one of those solutions that you can use. And I'm gonna talk specifically about anterior superior, which in my opinion up till now is very, very challenging, especially if you have a irreparable rotator cuff tear. So what we do in cases when you have the anterior superior rotator cuff is torn, especially if you have advanced fatty atrophy of the subscap. And what do you do in these? You have someone who has fracture after hemi and young patient. We're talking about young patient, by the way. We're talking about someone in 50, 40, maybe 60 maximum, and they have a subscap failure. Do you want to convert them to a reverse, or can you do something else? And worse is this, because now I have at least 16 patients, maybe more. We're going to publish about this. Because as you know, in Europe, letargie is very common. In the United States, become very, very common. Unfortunately, not everyone knows how to do letargie very well. And you end up with someone very young, someone who's 20, has failed letargie, anterior glenoid bone defect, no subscap, and start to have arthritis. That is very, very bad. This is someone you don't want to see in your clinic, but you see them. And what do you want to do for this one? So, and most of these patients, whenever they come, some of them, they're okay, but some of them, they have pain, instability, limited range of motion. And the question, what are transfer options that we can talk about? Now, the principle of tendon transfer is the same anywhere, in the foot, in the wrist, and the shoulder. The mechanics, the line of pull, the vectors are the same. So, originally, these are the techniques that have been described before. So whenever we talk about the posterior superior rotator cuff, it used to be latissimus. Anterior superior rotator cuff, it used to be pectoralis. And for years, when I was back in Boston like 13 years ago, we used to have very high failure rate. And I couldn't understand why. But we keep on doing it, by the way, because it's the only thing published. It doesn't work, but this is it. We keep on doing it. But this is what's described. And I think in a minute I'll show you what I think the misconcept about it. If you look at it in 2D, in two-dimensional, okay, is the pointer work? No? Does the pointer work? Yeah. Okay, thanks. So in 2D, if you look at it this way, honestly, if you look at it this way, look, this is a humeral head, this is anterior. So if I transfer pect minor, it looks like a subscap. No, maybe transfer deep to the conjoint tendon, look subscap, or no, better pectoralis major. In 2D, this is correct. But in 3D, it's not correct, because the line of pull is completely different, whether you put the pectoralis superficial or deep to the conjoint tendon. So I cannot deny, and this is one of those things, like SCR work, pectoralis major work. Sometimes I don't know why for the pectoralis. For SCR, I understand the concept, because you try to stabilize the shoulder to restore the force couple. But for pectoralis, I'm still not sure why they work, but they do work, especially Christian Gerber talked about the long-term result as well as Herbert Resch. So because they were not working my hand, especially with anterior subluxation, I thought, what if we take the latissimus? I know we take it posterior. Why do we take latissimus as a posterior tendon and you move it to reconstruct the subscap? It makes much more sense. Why? Because it's a posterior muscle, and I'll show you mechanically how it looks like. The other muscle is teres major. Teres major is very attractive, but it's very chubby muscle, it's very big. And if you transfer it very high, it may compress the axillary nerve, but it is possible because it's originated from the scapula, it's like a subscap, and you can transfer it to the proximal humerus. Like this is a patient who had the latissimus flap before, so I could not transfer from him latissimus. I transfer from him, this is teres major, but you can see it's the chubby short muscle. And if you look at the teres major, when you dissect, and this is your axillary nerve here, and you transfer the teres major, It looks pretty good, but what we notice is we put it very high, it compresses the nerve. I'm not sure clinically what is relevant, but it is a possible transfer. Now, we did the biomechanical study. Everything we try to study, we go anatomically, biomechanically, clinically. And JD, hopefully his name is becoming more and more. He came and spent the year with us, and we studied in a very, really state-of-the-art model, the biomechanics of tendon transfer, especially latissimus. And it does show, especially in abduction, the latissimus is much better transfer for internal rotation and for shoulder stabilization than pectoralis. Now, this is an animation. This is a chest fold. This is the scapula. This is where the pectoralis is. This is a latissimus. Look at the line. They're almost 90 degrees to one another. And this is where the subscap as well. So this is here. Look at this. This is, oops. Okay. This is, I did it, in fact, last week with my resident. I'm trying to explain to them. This is a chest. This is a scapula. The serratus is here. This is pectoralis. Why am I transferring this anterior muscle to this? This is latissimus, is coming from the back. This is the line of the subscap. This is where the scissor is. How am I transferring this muscle to restore that muscle? It's just, this is why biomechanically it really did not make sense for me. Now, they say, yeah, you put it deep to the conjoint, it will work. Well, this is deep to the conjoint. This is pectoralis, deep to the conjoint. And this is latissimus. You can see the line of the latissimus here. Look at the pectoralis. Now, once you internal rotate to neutral, look at the pect. It's still completely anterior, even though deep to the conjoint. It did not change. It's still on the anterior chest. If you look from the axilla, this is axilla, this is subscap, this is latissimus, this is pectoralis. Now tell me, if the shoulder is unstable, how are you gonna transfer this muscle to stabilize the shoulder? How this is gonna reconstruct this? This is why I don't understand why it works. Because biomechanically it makes no sense at all. But it works certain hand. Maybe the indication, I'm not very sure. But in 2D, two-dimensional, it looks like, oh yeah, it works. And I think conceptually, we used to talk about subscap is anterior, infraspinatus is posterior. So subscap, what's anterior is pectoralis, is anterior. But in reality, all the rotator cuff are sitting on the scapula, and the scapula is sitting on the posterior chest. So all the rotator cuff muscles are posterior muscle. None of them is anterior. And the pect is anterior. So, and how is it done? Like mini open, when you can do opening, small opening, and you can pass it arthroscopically. And arthroscopically, Jean Cani is here. I give him credit for that. He always liked to do sexy stuff, and this is how you can pass the latissimus arthroscopically. It's really not difficult as long as you know anatomy. You make a small incision and do it, or you can do it all arthroscopic. He's gonna show, I think, his technique today for all arthroscopic. And you can get the latissimus through anterior to the humerus, deep to the conjoint. You can see the latissimus here arthroscopically passed. And I'll show you inside. It's very easy because you already have two crackle suture in it, and you just anchor it. You put an anchor on the lateral lesser tuberosity, and you can see it coming in the shoulder, and you can anchor it. Of course, if someone has bone defect and require hemiarthroplasty or requires something like this, you cannot do it arthroscopic. And you can see this patient like unstable on the table. And if possible, I usually take the latissimus with a small piece of bone, like 5 millimeter piece of bone, to give it very good strength, and you can transfer it proximally. And if the patient have arthritis, I can do even some kind of arthroplasty and do it. So if patient has bone defect, subscap is gone, and some arthritis, you have to reconstruct each. For young patient, I don't do total, I do either resurfacing or stemless. For the bone graft, I use bone grafting for the glenoid, and I do latissimus transfer anteriorly. So this is for the exposure. And for the bone graft in the United States, it's easy for us to get osteochondral allograft. So very, very often I use either tibial plafond or I use glenoid osteochondral allograft. This is for the glenoid. We do resurfacing arthroplasty, and you do latissimus transfer. And this patient had 6 surgery before. This is him. He was really unstable on table. And we did it for him. This is another patient who had pec transfer before that's failed and had other 3-4 surgeries. And they're doing really extremely well for this very difficult category of patients. With Jean Cani, we're talking about, we have 2 studies right now. One is about latissimus for subscap only, without bone reconstruction. We have 72 patients. We excluded the bone reconstruction. We have very good result, and we are in the process of talking about or publishing about the difficult category of bone defect with or without arthritis and subscap insufficiency. Thank you very much.